Today, we're going to be talking about total knee replacements, and we have a special guest, Tony Maritato. He is a physical therapist with Total Therapy Solutions, and you are a PT based out of Ohio, and you also have different YouTube channels for certain injuries, including a lot of videos on total knee replacements. And I believe you have a Facebook support group for total knee replacements with over 7,000 members. We are really big on support groups as well. We have our company, our sister company is Evercore, and we have different injury recovery support groups as well. So Tony, it's really good to have you. I've been meaning to connect with you for a long time. So just give us a little bit more about your background and the types of injuries that you see in the clinic.
Sure, Mark. Well, thank you for so much for having me. I always enjoy coming on other broadcasts and talking. So my name is Tony Maritato. I'm a licensed physical therapist. I own Total Therapy Solutions, and we started the practice actually back in 2002. So 20 years in private practice. Over that time, I've treated everything from, post-surgical cases to persistent pain issues. My background, even before that, I was a certified strength and conditioning specialist. I was a personal trainer. I started all cash-based as a personal training studio on Siesta Key in Sarasota, Florida. And over the years, I just found a passion in working with clients who have had total knee replacement surgery. I felt like there was this huge gap in the market. I felt like they weren't necessarily getting the kind of therapy that I believe they should get. I felt that there was a mismatch between what therapists learn in school and the reality of treating real humans who have had a knee replacement. And then if there was a secondary condition I specialize in, it's post-surgical rotator cuff repair. That's another passion of mine. But anything your audience would like to hear about total knee replacement, I've been doing it for nearly 2 decades now. So while I may not be the expert, I've seen a lot of examples and heard a lot of stories, and I can share a lot of information about it.
Yeah, 2 decades is quite a bit of experience. I have about 9 years under my belt as a PT. And something, when you go search for total knee replacements online, and if you go on YouTube, your videos are bound to pop up. You have like 3 or so videos that have over 1 million views cumulatively about sleeping positions and pain management after a total knee replacement. So I wanted to help people out, those of you who are either thinking about getting a total knee replacement or who have had one and are anticipating recovery and you want to have a successful recovery, or maybe you want to minimize any of the complications that might occur after surgery. I want to be able to help you out with that. And Tony is your guy to help you. So hopefully we'll be able to get into some good topics today and just share some stories from the clinic about how to successfully rehab from a total knee replacement. So Tony, what are some of the delays that you've seen both in the clinic and in the research with total knee replacements? If somebody already had surgery, what are some of the things that limit recovery?
Well, certainly there's the stuff that everybody talks about, like there's risk of infection. We know that infection is very real. We know that lots of infections happen in the hospital and then within those first couple of days back home. So one of those cases would be somebody develops an infection following surgery. They have to return to the hospital, probably start IV antibiotics. And in some cases, they actually have to have a revision of the implant. Everybody, including the surgical team, the hospital, everybody is doing everything they can to avoid the possible risk of infection. And I would say one of the greatest services that a physical therapist can deliver, whether it's a therapist coming to the patient's home or the patient going to outpatient therapy in the first couple of days or a week after surgery, is just to monitor for that. Everybody's going to have pain. Everybody's going to have swelling. Everybody's going to have these characteristic symptoms, but an underlying infection can kind of sit in there. And when somebody is seen, hundreds and hundreds of knee replacements over the years, and there's that outlier that you say, well, something's just not right. Is this a possible infection? Is this possibly cellulitis? Is this possibly something else like a blood clot? I think a well-trained therapist can at least see potential signs of that and point that patient in the right direction to go get it checked out, go to the emergency room. I can honestly say in 20 years, we've probably had a handful, maybe 3 or 4 cases that first time I saw the person, I said, we need to get you to the emergency room, either because of an infection or a possible blood clot. So that, in terms of delaying the progress, delaying the recovery, infection is probably the number one thing we want to keep an eye on.
Yeah, and the physical therapist might be one of the first individuals to recognize the infection. So until the first visit after post-op, you might be waiting to get the Band-Aid removed, but in that time, you might have some redness, excessive swelling, maybe some leakage from the incision.
Especially these days, where most of my patients are not going to home health or receiving Medicare Part A home health services. They're not going to a skilled nursing facility. It's an outpatient procedure. They're getting a total knee replacement done at 8 or 9 a.m. and they're back home by 2 or 3 p.m. And so there's nobody there to help monitor the situation aside from family and friends. So having a professional eye, on the scene is really helpful.
Yeah, I think getting an infection is kind of the elephant in the room. That's the thing that probably everybody's afraid of the most. I was reading a statistic saying that out of one of the most frequent reasons for revisions and getting another knee replacement was 36.1% was having an infection. 21.9% was having aseptic loosening. So that's having loosening of the prosthesis that's not related to any kind of complication or infection. And that's related to the amount of wearing down of the prosthesis. And that can cause some reaction with bone, and it can cause osteolysis, which is basically some of the bone breaking away and breaking down. And also periprosthetic fractures that accounted for 13.7% of revisions. And that's where you have the bone that can fracture. So these are some of the, most worrisome complications, but the majority of people are not having infections. Is that right?
That's absolutely right.
Yeah. What are some of the other types of delays that you might see after knee replacement when you're trying to, work with somebody? What are some of the things that just kind of have you scratching your head, or maybe you're it's raising a yellow flag or a red flag during the rehab process?
I think probably the most common is just poor pain control. Unfortunately, now I like most of my patients are one of those people that you want to avoid pain meds as much as possible. I've got my wife who is always sensitive to pain meds and ends up with nausea and vomiting. But poor pain control does make the rehab process a little more challenging. It increases anxiety, it makes sleep difficult, and those things, of course, increase the sensitivity to pain. And so you're on this kind of perpetuating cycle where it's like, I can't move it because it hurts too much. It hurts too much and I don't move it, which causes it to hurt more. It increases some of the fluid that's just sitting in the joint. So I try to educate the best I can. Certainly as a physical therapist, I'm never going to prescribe medications. But the reality is, if the surgical team, the physician, the surgeon has prescribed medications to be taken on a regular basis, assuming there isn't a negative reaction to those medications, this is the time for the medication, especially in those 2 to 4 weeks right after surgery. We want to manage that pain. We want to make it reasonable for you. Yes, this is a major surgery. Yes, they've cut through multiple layers of soft tissue. They've cut through bone. They've put implants in there. If anybody's taken the time to watch the procedure on YouTube, it's quite an aggressive procedure. And so I always try to explain to patients, imagine you were in a car accident. You broke both your tibia and both your femurs. You had to go into surgery. You had a laceration that went all the way down to the depth of the joint. They put everything back together. But the difference is, in that situation, you probably wouldn't be up walking the next, that day and the next couple hours. You wouldn't be doing all of these things. So we need this pain to get under control. We need to bring the anxiety levels down. We need to acknowledge that, yes, there's going to be soreness, discomfort, there's tissue trauma, but it shouldn't be miserable. There shouldn't be suffering with this. And so we want to figure out, are we missing something? Because the pain is so intense that we can't get the range of motion. We can't get you on your feet. We can't get you moving comfortably. Are we missing something, or are we just not appropriately treating the pain? And certainly there's different pain medications, and I've had patients that respond to all sorts of different things. So if what you've been prescribed isn't working, go back to the surgical team, let them know, and they will try something else.
Yeah, I definitely agree with that. That's a conversation you have with almost every person that's had a total knee replacement. It's about pain management. And like you said, those first 2 weeks are really important because you want to be able to work on mobility and range of motion, and you want them to be ambulatory and you want them to move. And if, so basically that's a time when they should be taking their pain meds, if it's appropriate and the doctor prescribed it, if it's at any time during the rehab process. Those initial first 2 weeks are really painful, and they can be painful. And so you don't want to, refrain from taking the pain meds and then limit your range of motion because everything hurts too much.
There are
That's a
some
time.
there are some really great videos, TED Talks talking about pain medication, talking about pain addiction to pain medication. And I think, like most things, we kind of take a position and we maybe take it too far. The pendulum swings too far. And so there are some great studies that looked at different populations that even when they were addicted to opioids and certain drugs, that when the environment changed, when the situation changed, their addiction changed, and it was no longer an issue. And so while we want to be mindful of the reality that there could be some dependence that builds up, these pharmaceuticals are there for a reason, and this is absolutely the time to use them.
Yeah, absolutely. What about range of motion? What are some of the factors that might limit somebody's range of motion after surgery? Because I know it's really important to get to certain milestones with both flexion and extension.
Yeah, this is probably where I start to diverge with the general physical therapy population and orthopedic group. Because I have a YouTube channel, I get the good fortune of interviewing various surgeons, people that are boots on the ground and they're really in there. And some of the things that we talk about related to range of motion are really interesting. Certainly we're concerned about scar tissue formation. Certainly we're concerned about limited range of motion. But I can tell you, 20 years of history, seeing people come through this procedure, I've seen people do everything that we would consider as classically wrong and have amazing range of motion. I've seen everybody do everything we consider as classically correct and have real big struggles gaining their range of motion. I've seen everything in between. So a couple of things that I believe are important related to range of motion that really aren't discussed typically in this conversation. When you think about, there's going to be a size of the implant that needs to put in. Certainly there could be biases to a larger implant, a smaller implant, but the size of the connective tissue before surgery relative to the implant going in during surgery, when you close that back up, there's a very real possibility the joint capsule, the ligaments, the connective tissue that's holding the knee together just doesn't have as much room as it used to, especially when you consider the previous knee might have had degenerative changes, might have had some atrophy, might have had bone loss. And so now we're putting in this prosthesis that is just not the same size. And so one reason why I see people struggle with range of motion, I believe, is because the connective tissue just isn't big enough to accommodate the implant that's put in there. Doesn't mean that it can't be improved. It just means that it's more of a challenge. The other part with range of motion is, we have to remember pain again. Pain is going to limit range of motion. If I bite into a jalapeno pepper, my lips feel like they're on fire. No matter how much you tell me when I'm asleep, my lips aren't burning, just like they tell you when you're asleep on the operating table, they bent your knee into full flexion. When you feel that fire on your lips, when you feel that pain in your knee because they're trying to bend it and it won't bend, it's real. It's very real pain experience. So we have to be able to understand that the reality is there's disruption to the lymphatic drainage system. There's disruption to the circulatory system, to the skin, to the nerves. Everything has been disrupted. And so we're trying to calm all of that down to allow the knee to move through as close to a full range of motion as possible. I'm not a real big believer in, yes, there's tissue healing timeframes, and we want to gain range within the timeframes that are kind of established. But when somebody comes to me and they're 12 weeks post-op and they're still not at 90 degrees, one of their common questions is, will I ever be able to get to 90 degrees? And my typical answer is yes. I mean, we're dealing with human tissue. Human tissue will always adapt to the stresses placed upon it, as long as those stresses are placed on a gradual basis. I can bend a bone if I do it gradually over a long enough period of time. So we can always increase and regain range of motion, but we have to do it correctly. And that's where I will tell my patients in my clinic, you might not get the range of motion as quickly as your neighbor did, but we're going to compromise, because I'm not going to make you suffer, and I'm not going to make you worse after your therapy session. So for the next 24 to 72 hours, you can't function. My goal here is build confidence, build your capacity to do the things that you want to do. You didn't have a knee replacement so you can measure 140 on a goniometer. You had a knee replacement so you can hike and you can garden and you can play with the grandkids and do the things that you love. That's what we're going to focus on. And universally, I've still to this day never met a person who, if we focus on doing the things that they enjoy, wasn't happy with the outcome. It's when we focus on the goniometer, which, I mean, seriously, it's 5 degrees off, up or down on any given day, even for somebody who's trained in how to use it. It's a very inaccurate measurement. Let's just focus on the things that you want to do and make sure you're able to do it.
Yeah, I agree with that. I tend to be pretty conservative when it comes to the guide, the milestones or the guidelines with range of motion, because, the pain levels could be changing, somebody's, emotional state, or just the regular healing time that they have. The tissues go through different healing time.
Yeah.
So if it's 2 months out and you're severely limited with your range of motion, then maybe I'm going to, talk to the surgeon. But if it's just you're minus 10 degrees or minus 5 degrees from where you should be just 3 weeks out, I'm not going to freak out yet, because there's still going to be some time to regain that range of motion. And oftentimes, if you start to see a delay in the clinic with range, you'll tend to get it back within the next 1 or 2 weeks with just some really gentle, low load stretching, especially if somebody's not tolerating the stretching, the more aggressive mobilizations. That's something that, some people just don't tolerate aggressive mobilization to the knee, and they just need a little bit more frequent, low load stretching. And that seems to help out a lot. I was going to ask if you have any kind of favorite positions or techniques for gaining range or improving extension or flexion.
Yeah, I mean, one of my favorite, like I always say, if I'm working on knee flexion, and I'm sure people listening to this have had a therapist, grab their ankle, grab their shin, push back on their lower leg to try and bend the knee. As soon as I hit pain, as soon as I hit any resistance, any possible improvement I can deliver is gone. Like there's just no chance. So when I have a student in the clinic watching me do joint mobilizations on a post-op knee replacement, they're always shocked at how gentle and how lightly I'm actually pressing, because once that guarding response kicks in, there's no more benefit. But what I have found, and my absolute favorite way for an individual to work on knee flexion, is any variation of kneeling. Now, the first response when I say kneeling on a total knee replacement, especially 3, 4, 5 weeks post-op, is, hesitation. And certainly if there are staples in the incision, we're not going to be kneeling just yet. But there are lots of versions of kneeling. So a lot of times I'll get my patients to lay on their bed, roll into prone. So laying, am I still there? Because I'm frozen on my side.
Yeah, you're frozen, but I can still hear you.
Okay, well, we'll keep going for the audio.
Yeah, good. Yeah.
So I get my patient in the clinic on a plinth, on a mat, but at home, I tell them to do this on their bed. They would lay on their back, call a prone hang, letting their foot or ankle hang off the side of the mattress. But then I'll have them kind of push themselves back into a quadruped position. And I've yet to this day, I have never found an individual who is unable to tolerate quadruped on the bed, hands and knees with their feet hanging off the back edge so that there's not excessive knee flexion. And from a joint mobilization perspective, as a therapist, that the tibia needs to move posterior relative to the femur when we're flexing the knee. And so in that quadruped partial kneeling position, the patient is doing their own joint mobilization, and they're doing it more aggressively than I would ever do it. They're doing it with less pain than I would ever do it. So that's absolutely my favorite way to work on knee flexion. Sorry, I don't know why.
Yeah, the video cut out. Not sure why. Can you still hear the audio?
Yeah, I can still hear you.
Okay.
Do you want to try to restart it?
We can try, yeah, because then we can just, splice it together.
Okay.
So let me restart it. Let me end it and
same link.
Yeah, you know what? We'll just continue because I'm gonna have to leave for a patient pretty soon.
Okay.
And I'm at my house right now, so that's okay. Maybe I'll add your photo or something.
Yeah.
Yeah, the quadruped knee mobilization technique. I don't see that too often in the clinic from other therapists. And if I'm going to do that, it's usually a lot later in the rehab process. So it's nice that to hear that you initiate a quadruped position to work on knee flexion. I'd love to see that sometime.
Absolutely. I've actually got videos on my YouTube channel where I take a series of different patients and I show them in that position. One is like tall kneeling on a recliner. One is quadruped on a plinth. If somebody is just absolutely too sensitive through the incision, what I'll do, and you can visualize this since we only have the audio, is I'll have them stand. I'll have them place their like shin and foot over a bench, like a workout bench. They can also do it on a chair. And so the knee itself is suspended in the air. They're standing, but they're still getting that pressure through the tibia and it's still gliding posteriorly. So those have been absolutely the best kind of more aggressive, but self-controlled knee flexion positions that I've found. I've got a ton of videos on them. Just check out the channel.
Yeah, great. That'd be awesome for education and both for therapists and for the person who has the total knee replacement. Lastly, Tony, I was going to ask is, does inflammation play a role in the healing process? And also, what about ice and heat? I know you've talked about that in the past.
Yeah, that's another one where I just go way out into the left field, but there's absolutely research behind what I say. So one of the myths that I try to bust, and you may or may not agree, is I'll usually ask other clinicians, especially students, why do we still say, let's put ice on an inflamed knee to reduce inflammation? We know clinically inflammation is a chemical process. Inflammation is your immune system coming to the area, trying to remove the debris, trying to kill any bacteria or infection. Inflammation is immune regulated. Temperature change does not affect your immune system. And so for us to say, I'm going to put an ice pack on there, or worse, and the reason why I went down this road was because I would have patients who were highly sensitive to ice. They were miserable putting an ice pack on their knee. Yet because they were told by their surgeon, you have to ice, every couple hours, they were suffering through this horrible feeling. And I said, look, ice is about sensation. That's all. Ice is about making your skin cold, distracting you potentially from other things that are going on in the knee. If you believe there's any benefit to icing, it's purely sensory. Icing does not reduce swelling. Perhaps the weight of the ice will press down on the tissue and squeeze some of the swelling out, but the actual temperature of the ice does not affect swelling. Yes, it'll affect the superficial skin. Yes, it'll affect the capillary beds in the skin, but we're talking about a deep tissue issue here. We're talking about deep to the joint, deep to the bone. You are not going to change the temperature that deep with most conventional icing methods. So if ice feels good, go ahead and do it. If it helps you move more and builds your confidence, go ahead and do it. The movement is what we want. But I've talked to more and more people who have gone the heating route. They put either moist heat or an electric hot pack on it. It's soothing, it's relaxing, and makes them feel good. Again, it's just sensory. It's not really doing anything deep to the tissue. And so our ultimate goal is movement. The more we move, the more we get somebody up on their feet. The knee is designed to bear weight. And so if we can load that joint and build confidence in the person who had the knee replacement, they are going to respond better. The knee will always respond better with active activity as
We lost internet connection with Tony. And if life hands you lemons, then make lemonade. This is going to be part one of our interview with Tony Maritato. We were talking about different issues that can arise when you're rehabbing after a total knee replacement. We'll do another interview with Tony since we lost connectivity. Sometimes that happens when you're trying to rehab, or whether you're trying to do an interview, sometimes it just doesn't go your way, but that's okay. It's all about making the most of the situation. If that happens during your rehab process, you just still need to be positive and realize that you will be getting better. And who knows, maybe you're going to be learning from the situation, and this will prevent a worse problem from happening in the future. It's all about your perspective. So, but Tony was talking about inflammation. He was talking about using ice or heat and whether or not that helps with inflammation. Inflammation is an important part of the cellular process with healing. It does affect the synovium, which is the fluid around the knee joint. There is a membrane that produces a fluid that's almost like egg white. And sometimes you can have too much inflammation in the knee from a local reaction from the soft tissue and from this out of control immune response. And if you are dealing with excessive inflammation, you can head over to activeatoms.com. There are a lot of articles about the effects of curcumin and how curcumin could influence and promote a healthy inflammation response. So sometimes you don't want to completely reduce inflammation, and other times you want to minimize it because it's a little out of control. So if you want to learn more about the effects of inflammation on the body, then head over to activeatoms.com. If you want to learn more about total knee replacements or join Tony's group, then go to YouTube. That's probably the best way, and type in Total Therapy Solutions. You could find his videos there with more information about total knee replacements and about rehab. And you could also join his support group on Facebook, so you can be connected with other people who are going through this injury. Let me know if you have any questions, and hopefully I will see you soon.